Hello and welcome from New York City. My name is Diana Diaz Munoz. I am the Director of Capacity Building in the Viral Hepatitis Program at the Department of Health and Mental Hygiene. And first and foremost, I would like to thank Nacho for the award of model practice. We are very grateful. And we're going to introduce the rest of our speakers today. I'm going to pass it over to Farah.
Hi, my name is Farah Biasi. I'm the Healthcare Practice Facilitator Director at New York City Health Department and the Viral Hepatitis Program, and I'm going to pass it over to the REACH program to introduce themselves. Jeff, take it over.
Hello, Jeff Weiss. I'm the director of the REACH program at the Icahn School of Medicine at Mount Sinai. I'll pass it over to Jacob.
Hello, everybody. My name is Jacob Herrera, and I'm the Hep C program coordinator for the REACH program. And I'll pass it over to my colleague, Irina.
Hello, my name is Irina Fuso, and I'm a community health worker with the REACH program. I'll pass it to Reggie.
Hi, everyone. My name is Reggie Idlet, and I'm a community health worker at the REACH program.
I'm going to share the screen now. Can I get, can you see my slides?
Yep.
Okay. All right.
Great. So today we're going to be talking about no missed opportunities, a client-centered telehealth model for hepatitis C in inpatient substance use treatment programs. And as you have seen, we have colleagues from both the New York City Health Department and from the REACH program at Mount Sinai Hospital. The learning objectives for today are to understand the syndemic of hepatitis C virus, which we'll talk about as HCV moving forward, for the infection and substance use and the structural barriers to access, prevention, testing, and care. Also, to identify opportunities to address care cascade limitations that impede HCV treatment access and continuity of care for inpatient substance use treatment program clients, which we'll also refer to as ISUTP. And to describe a telehealth model supported by community health workers. And finally, to propose strategies to reduce care drop-off post-discharge and apply lessons learned in these settings. Next. So I'll start over with some background. And for anyone who may not know from New York City, our prevalence of chronic hepatitis C as of 2023, it's about 62,813 people. And this number has decreased over time thanks to the availability of direct-acting antivirals and the many interventions that have been implemented in the city. It is estimated that this number represents 0.8% of the New York City population. In this graph, we are showing the percentage of people that have been cured or cleared in the past 10 years, from 2015 to 2024. And as you can see, over time, the window of clearance and cure narrows for the patients who have been identified in prior years, and it still remains a challenge to start people on treatment and for them to be cured within 1 year of diagnosis. Here we wanted to show you some results from a enhanced surveillance survey that was conducted by our colleagues in the surveillance team. And this shows the percentage of people ages 18 and older who were newly reported with hepatitis C and were investigated. And And we're showing the reported risk factors from this group, which highlights that injection drug use was reported by 33.3% of the people that answered the survey who had chronic hepatitis C, as well as intranasal drug use appearing as the fifth risk factor, with 15.2% of people with chronic hepatitis C. I'll pass it over to Farah.
Thank you. This quote, it's really what we're trying to showcase in this presentation. I'm not going to read it all, but just wanted to highlight the last part, that preventing treatment for opioid use disorder can improve outcomes for people with infectious disease, and at the same time, identifying and treatment in infection diseases can minimize the harms by decreasing the risk that the disease will spread, and just highlights the importance of this intertwined epidemic. With that in mind, we know that there is a cycle of a stigma that really limits the care and access, and really delays hepatitis C care. So people who use drugs may share injection equipment or drug use equipment, and that can increase the risk of hepatitis C transmission and reinfection. That can really put in a stigma, and also related to that can affect an unstable access to care. And this is really what we're trying to prevent in this model, is the delay in diagnosis and treatment. So with that in mind, before we had these this specific grant, we looked at some data that is a little bit outdated, but really to try to highlight where to put the resources and to put things in perspective. Looking back at data from 2017 to 2018, we identified 17 of the 24 New York City inpatient substance use programs had a high prevalence of patients with hepatitis C. And among those patients that were unhoused or had history of inpatient substance use, attending inpatient substance use programs, only around 12% of those clear hepatitis C within 6 months, compared to others that had none of these risk factor history, that was compared to 27.2%. So inpatient substance use programs are those where clients may be there for hours to around 28 days for either withdrawal management or rehab. Most of them have under-resourced to deliver hepatitis C and hepatitis C coordination for treatment, and many clients are referred actually after discharge for hepatitis C care. When looking at different data, telemedicine integration, it's one of the models that came up. Specifically, a model where they were doing outpatient OTPs, hepatitis C treatment through telemedicine, where they had a 92.4 of a start treatment on site versus with telemedicine versus 40.4 when referred to a provider outside the site. And the other thing that is highlighted in this specific paper is that there was high client satisfaction that was reported when there was integration of hepatitis C and medication for opioid use disorder care. So in 2021, the New York City Health Department got a 2103 grant that was specifically focused on improving access to critical services for people who use drugs or inject drugs. And it was focused on many different components, for example, hepatitis C, hepatitis B, and HIV testing and treatment, harm reduction services, medication for opioid use disorder, vaccination for hepatitis A and B, primary care to prevent health complications, and really the intervention that was proposed, and what we are going to talk in this presentation lengthy is spokes and hub and a spokes model of care using telemedicine, and this was administered by New York City Health Department. This is a 5-year grant. Right now, we're in a year 5 extension. It was from May 2021, and we're in the last year that will go until April 2027. So how was the hub and the selection of the spokes? So for the hub, we selected the REACH program at Mount Sinai Hospital because they had some of these qualities and they were already providing some of these care. For example, telemedicine was already a component that they were offering with hepatitis C treatment, medication for opioid use disorder, alcohol use disorder, and primary care. They already had experience treating patients who use drugs in a patient-centered manner. And they also were providing naloxone by being an opioid overdose prevention program. They also were a second-tier syringe exchange program. So for all those reasons, they were selected as the hub. For the spoke selection, we selected 2 detox rehab centers. They were brick and mortar sites, apart 816 and or 818, providers certified by OASIS, and they were chosen out of 5 substance use treatment programs with a high burden on hepatitis C based on surveillance data that we had. And they had a minimum of 400 annual discharge. So this is what it went when selecting the spokes and the hub. Jeff, I'll pass it to you.
So to fill in a bit more about the REACH program, we're based at an academic medical center in New York City, and our primary care program serves approximately 400 unique patients a year. Patients come from all over the 5 boroughs of New York City, predominantly male, racially, ethnically diverse, and the majority of our patients have low income. 63% of our patients have Medicaid, 28% Medicare as their primary insurance. Our patients report high rates of homelessness, 24%, and 58% of our patients report injecting drugs within the last year. Of those, 63% have an opioid use disorder diagnosis. Next slide, please. To give the full scope of our program, we are a primary care program providing the services that Farah mentioned in a clinical setting, as well as doing telehealth treatment. We also have a separate program that's co-located in a syringe service program in Brooklyn, New York, where we provide low threshold services to clients of that program, including hepatitis C treatment. We collaborate closely with our health system as a whole, our emergency department, the inpatient units, try to focus on bridging transitions of care across the health system. And we have a robust community outreach program that includes now point of care, Hep C RNA testing, overdose prevention, and outreach events to identify new individuals who might benefit from our program services. And finally, we're actively engaged in education, research. We have a clinical education initiative funded by the New York State Department of Health to educate healthcare providers throughout New York State on hepatitis C and drug user health, and also have many initiatives to improve the care for individuals with substance use disorder across our large health system. Mount Sinai is a health system including at least 9 different hospitals. Next slide, please. So the model of care is grounded in harm reduction. It's patient-centered, and we try to co-locate as many services as possible so that there's no wrong door for patients and they can access whatever services they're needing. In the clinic, we have co-located mental health services, psychiatrists, therapists. We try to bring the voices and views of our patients into our work through a consumer advisory board, Many of our staff are engaged in advocacy initiatives, collaborating with patients to advocate for the needs of individuals with substance use disorder. And we also offer support groups, harm reduction support groups, as an alternative to the more traditional 12-step groups that are widely available in New York City.
Thank you, Jeff. So when we were looking at the project objectives and activities for this specific grant, and looking specifically at the objectives and activities for the hub, these are the main things that we required from the Department of Health. So a project manager is specifically for the hub to coordinate and document monthly project status, attend meetings, etc. We also asked for a workflow implementation and evaluation, so that's to assist the spokes with creating a referral workflow for medication for opioid use disorder, but also for hepatitis C treatment. There was a minimum of at least 20 engaged clients or patients for hepatitis C treatment and medication for opioid use disorder. All this information needed to be entered into REDCap. And we also encourage the program to disseminate the findings from the model and disseminate the model and the outcomes. For the spokes, these are the main project objectives and activities. They needed to have training not only for non-clinical, but also for clinical staff. They had to complete education on hepatitis C basics, etc. They also had to create a workflow development, specifically when the clients came during intake, to testing, to treatment, and how those referrals will work. They also had to enter aggregated data for into REDCap to have level data on the different components that we were evaluating, and at least identify a minimum of 100 HCV RNA positive clients that needed to be referred. At least 75 of those needed to be referred for medication for opioid use disorder and hepatitis C care. So in this map, we can see the rate of newly reported hepatitis C cases in New York City and where the location of the different spokes and hub were located. The spoke was located in Manhattan, in this area. The darker blue represents the higher rate of newly reported hepatitis C clients or population. A, C, and E are spokes one. Spokes one had 3 different locations, and these are the different locations. And there was the second spokes, which is only had 1 location, represented by letter D. I'll pass it to you, Jacob.
Thank you so much, Farah. So now with this slide, I'm going to go over a little bit about our model overview. So this is a visual breakdown of how our model operates. Our team here at Mount Sinai REACH program is located in the center as the hub. And so the connecting piece that makes our model work so effectively is the on-the-ground work done by our community health workers. And those essentially are our linkages to the spokes. And because of the access that we have been granted, we are able to link patients to our program who are admitted inpatient at one of our sites while admitted. This linkage is done mainly through telehealth. And so we bring the care directly to the patient through the work of our community health workers with our providers. And our goal is to identify patients as soon as possible to get them linked to us before they leave their respective programs, because as we know, once they leave, a person has a wide variety of circumstances that they're dealing with, and it may be hard to re-engage with the person after they're discharged. We also try to lay down the groundwork for building that relationship with the individual that we're hoping to link, so that once the person does discharge, we're still able to follow up with them for across the continuum of care for Hep C care specifically, but also in general primary care. And next slide, please. And so here is a breakdown of, as mentioned, we have a partnership with Spoke 1, which is the 3 sites, and then we have Spoke 2, which is just consists of the 1 site. And so at Spoke One, the access that we've been given at our partner, or sorry, the access that we have been given at our partner sites varies slightly between Spoke One and Spoke Two. So at Spoke One, this consists of 3 programs as mentioned, and here we've been given full access to their electronic medical record. And so this has shifted the burden from overwhelmed staff at these programs to our team. So our team is allowed to do chart reviews, review the EMR to try to identify individuals in a timely manner. And so some of the work that our community health workers do is we provide education. We assist patients with whatever needs they may have in terms of healthcare. We schedule telehealth visits. We facilitate telehealth visits. We work with the pharmacy and the pharmacy liaison to troubleshoot any insurance issues. And we coordinate linkages to care and follow-up visits for people once they leave the program. And so at Spoke 2, as mentioned, this consists of only 1 location, and we've been given some access, but definitely not to the same measure as at Spoke One. And so, yeah, community health worker there is not co-credentialed in the same way. And so the access that the community health worker does have is to the floors to meet with clients, but no real access to their EMR, which at times make it a little difficult. So we do work very directly with the on-site staff to provide us with information that we're not able to receive. And yeah, so we're really dependent on receiving referrals from the counselors and the medical team there, as opposed to at Spoke One, where we're the ones mainly identifying individuals through chart reviews and things like that. Next slide, please. So now with this slide, I just want to highlight the model evolution and identify some of the barriers we've had to overcome. And so with this in the visual, we broke it down into 3 phases. And so phase 1 was the beginning of our collaboration when we first started. And at this point, Reach had very minimal access to our spoke sites. And during this phase, there were several logistical challenges that existed between the hub and the spoke staff. One main challenge during this period was that Reach had no access to the program's electronic medical records, which made it very difficult to obtain patient information like previous labs and contact information in order to contact individuals once they leave the facility. Also, since our program was only telehealth at this point, we had to rely entirely on the spoke staff to outreach patients, collect patient information, and facilitate telehealth visits, which made it extremely difficult to link people, especially with the workload of the staff there that they already have apart from this partnership with our Reach program. And phase 2 began toward the end of the second year of the grant. And in phase 2, this is when a community health worker was hired at Reach. And so the community health worker worked as an in-person liaison to link individuals that were admitted inpatient at the time. And our community health worker was able to be on site at our partner facilities, which allowed for an increase in communication with patients and resulted in more people being linked to Reach. And then in phase 3, this began at the beginning of the 3rd grant year. And so during this time, a second community health worker was hired, and both of our community health workers were able to be co-credentialed at our partner sites in Spoke One. And so this gave us access to the program's electronic health records to review labs, view relevant medical history, gave us access to their Microsoft Teams chats, which allowed us to speak directly with the staff. And they also gave us a badge in order to be on site to conduct outreach and facilitate telehealth visits. And also in phase 3, we established a workflow with our pharmacy here at Reach, which is co-located here at the Mount Sinai Hospital. And so this increased the amount of individuals we were able to get started on treatment immediately. Next slide, please. Yeah, so and throughout the program, at certain points, we saw major improvements when it came to linking individuals. And in phase 3 is where we saw the greatest improvements in our program. And this was a result of innovations in 2 key areas. The first one being our staff being co-credentialed at our partner sites. And so since our outreach team is now all co-credentialed again at Spoke One, our partner sites, this grants us access to their electronic medical record, which has increased our autonomy and has allowed us to proactively identify clients with Hep C by doing weekly chart reviews, hoping to catch individuals that are only admitted for a short time. The length of stay varies from person to person. So it's very important that we're able to identify somebody at the beginning of their stay, because it may take some time to either some motivational interviewing, or we have insurance to work on. So we try to give ourselves as much time as possible to really link the individual as soon as possible. And so in addition, we were also given site-specific email addresses that allow our outreach team to confidentially communicate with the on-site staff through Teams and Outlook. And so having this access allows us to communicate with counselors and medical staff for things like new patient referrals, appointment reminders, and medication deliveries. And the second key area of our program innovations is our pharmacy collaboration. So we have now established a workflow with our pharmacy team that allows us to expedite the process of individuals getting their medication. We have a specialty pharmacy co-located in our facility, and we are in constant communication with the staff to identify and resolve issues on behalf of our patients. And a key part of our collaboration is the work done with the pharmacy liaison. And so with this relationship, prior to every appointment, we send the pharmacy liaison the patient's insurance information to ask that they run the insurance to ensure that it is active and that their Hep C medication will be covered by their insurance carrier. And during this investigation, the staff there inform us of any restrictions that they identify from the patient's insurance in order for us to work with them to resolve the issue so that on the day of their appointment, there are no issues with our provider prescribing medications and the pharmacy releasing their medication. And that way we can coordinate delivery of the medication as soon as possible. And so this pharmacy collaboration is essential to what we like to call our rapid start model. And as our relationship and workflow has improved, we have seen an increased number of individuals get started on medication. And so it is also important to note that not only has this led to more individuals starting their medication, it has also sped up the time it takes for a patient to receive their medication. And so we have come to understand, especially working with our patient populations in the settings that we are, that the sooner we are able to get someone started on treatment, the more beneficial it is for their overall health outcomes. And so these two are key reasons that really transform the way we operate as a program. Yeah, next slide, please. And so with this slide, I won't go over line by line, but this is a quick overview of our client characteristics from May 2021 to April 30th, 2024. And so as already mentioned, our cohort was made up mostly of men, with 84% identifying as male and 16 identifying as female. Race, it was fairly diverse, with the largest group reported white with 32%, and people identifying as Black or African American making up 30%. And so for ethnicity, the largest reported group was not Hispanic or Latino, was 46%. And for age, as you can see here, the largest age group we served were those from 40 to 54, making up 46% of our patients. Next slide, please. And so briefly here, I like this visual because I want to highlight a few points about the data that we just viewed. So as mentioned, we were able to enroll a total of 164 patients, with 83 or 51% of these individuals reported that they were unhoused. And so this is important to keep in mind when thinking about our target audience, because many individuals that we engage with who are reportedly unstably housed are not connected to healthcare and have not been for quite some time. Therefore, even if a patient is aware that they have Hep C, treatment could be looked at as difficult to obtain due to the process of going out of their way to find a healthcare provider when treatment might not even be a priority, considering they don't have a stable place to live. So this is a key part of what our model is aiming to do: reach the most difficult populations when we are able to, by directly bringing the services to them. And so in addition to that, 80% of our clients linked to us reported intravenous drug use. In the past 12 months, 86 reported that they were on some sort of substance use disorder treatment, and 24% of our clients were reportedly incarcerated in the past 12 months. And so all these points together really highlight the social determinants of health and really show the population that we're hoping to serve and do serve. Next slide, please. And then a quick overview of the care cascade for patients linked to us over the first 3 years. So here, as you can see, there was a major increase in initial visits. Our numbers go from 37 in year 1 to 39 in year 2. And as mentioned, in year 3 is when the innovations that happened. And so in that year, we saw a jump to 88 initial visits. So, and also major increases in people who started Hep C treatment from year 2 to year 3. As you can see, in year 2, 22 started treatment, while in year 3, it tripled and 66 started treatment. And again, this is when that collaboration with the pharmacy and the community health worker staff being on site really started being implemented into our workflow. And so also, as you can see, in year 2, only one person started treatment while admitted at their program. And in year 3, 51 were able to start treatment. And again, this we directly correlate with our staff's ability to be on site and take on the majority of the workload. And also here, I want to highlight again that at this time is when our community health worker started. So these 2 points that we already discussed, they're the key parts as to why our model we've seen increases throughout the years. So yeah, very key innovations there. And then another main takeaway from this slide is that I want to focus on the median time from the first Hep C visit to treatment start date. So as you can see, patients were being started earlier as our program evolved, but also you can see from year 2 to year 3 with the changes to our workflow, with the pharmacy, the amount of days dropped from 52 days to 5 days, which again, we found very beneficial for engaging with our specific patient population. And so by this point in our program, we have created a steady workflow that truly expedites the process of getting cured of hepatitis C. And so it is important to note that although our workflow is established, we do have ongoing challenges that we continue to face. And to discuss a little bit more about that, I will hand it over now to Irina.
Thank you, Jacob. I'll be speaking about some of the ongoing challenges we have when linking patients to treatment. So the first challenge is the insurance barriers. The REACH program is not able to accept Health First, United, and a few other insurances. So when we are unable to accept these insurances, we are not able to use this rapid start model. This means the patients have to be referred to another healthcare provider, which usually means they have an appointment post-discharge, which they are usually not able to make. And when they do have an appointment while they are inpatient, it takes a lot of coordination because they have to coordinate with staff from the program and it has to coincide with their availability. So when we are not able to see them at REACH, it's very rare that they can begin treatment. The next challenge is lab delays. Labs can take about 2 to 5 days to result. So this makes it so we are not able to identify patients in time before they leave. Withdrawal management is another challenge. Patients can be withdrawing, can be going through a lot of discomfort. This means that sometimes they are not able to speak with us community health workers. They are still recovering, they are not feeling well, or they are open to speaking, but as soon as the telehealth appointment arrives, they start to get sick and they can't go through the telehealth appointment. This withdrawal management also means that a lot of them leave the program early. The methadone, they're given a methadone taper that is not substantial enough to manage their withdrawal because they're used to self-medicating with higher dosages. So this discomfort makes it so they often leave early to go self-medicate or seek help at a hospital. So this is one of the reasons for the short program stays. They don't feel well enough to stay, or there's other reasons such as family dynamics or court dates. Sometimes psych issues. The patients need to see a psychiatrist or need higher treatment and they can't stay. And then lastly, post-discharge follow-up. So we've had a lot of success engaging clients in this setting, but if they leave early, or sometimes even when they leave after their 28 days, it's challenging to engage them because of their lifestyle. They're often homeless or they are in a long-term care facility that takes a while to get through to them because we're relying on staff. And then sometimes they leave those facilities. So engaging with them while they are inpatient is very helpful. All right, next slide. So as I mentioned, the core challenges are the post-discharge drop-off, the way we lose contact with them once they leave the program, and the social barriers that these patients deal with. So being homeless, not having a phone to stay in touch for appointments, for appointment reminders, to coordinate. So some of the high impact strategies that we have is we want to tailor a discharge plan while we meet with them. So, hey, if you were to leave before your 28 days, how can we locate you? Do you go to a specific food bank? Do you go to a methadone program that we could contact? Do you have a family member that we could contact? Or if they are leaving at their set discharge date and they're going to another program, such as a long-term care program, we give them an appointment for them to follow up with us. And we have them sign a third-party consent form, which means that we can communicate with them through either the long-term program that they go to, or if they're going to an outpatient program, we could communicate with them if we were to lose contact with the patients. We're able to give them phones so they can stay in touch with us. And then on those phones, we can set them up with MyChart, which is our platform, so they can communicate with their providers directly, see their appointments, be engaged in their care. And then building a network of programs so they can be engaged with us at Reach, but also with our partners at Vocal or our partners at different organizations. And meeting all their needs. So beyond Hep C, for them to come see us for primary care and build a community within our providers or our psychiatrists, our social workers, our support groups. These are ways that clients can stay engaged. All right, next slide. So I wanted to illustrate a success story that we were able to begin a patient on treatment successfully. So this is Mr. Dalton. This is not his real name due to privacy, but he was a 65-year-old Black male. Beyond his Hep C, he was someone who loved to sing. He loved to draw. He had a big sense of humor. The first meeting we had, he told me about funny stories about his time in childhood with his siblings. He told me about the drawings and the art he would make. So this is something that helps connect with clients when the community health workers have that time to not only provide education, but to connect with these patients. So that's a bit differently than the experience they have as if they meet directly with a provider who only has limited time. Mr. Dalton, as many of our patients, was homeless. He had been previously incarcerated, and he used drugs intravenously. He was diagnosed with Hep C in the 80s, and he said he believed he received a treatment, but he wasn't sure. And he said, so it was unclear if this was the same infection or if he had been reinfected. He told me that he had been diagnosed with Hep C several times in emergency rooms and inpatient settings, and either was not referred to a Hep C provider or was and just could not make the appointments. I remember he told me that the drugs would probably take his life before his Hep C, so he did not prioritize this, which I thought was it was just a very sad thing to hear. But I was able to identify his labs doing our chart reviews on day 3 of his inpatient stay. On day 5, we were able to connect him to the telehealth provider. And before this is when we had our conversation. I gave him the intro of how treatment would go. We had a little bit more of a conversation on who he was, his history, and then when he connected to the provider via telehealth, he was able to give him even more education about his Hep C and about treatment. I remember after he had his telehealth, he seemed very motivated and to start treatment, knowing and surprised of how easy it was. The day after his telehealth, we were able to bring him his medication. And then the next day, he started receiving treatment at his program. I followed up with him while he was at his program, as community healthcare workers usually do, to see how they're doing, begin discharge planning. And he told me how good he felt that he had started this treatment. He said that it motivated him to take care of his health. he felt very empowered. He was then discharged to a long-term care program where we were able to give him his second box of medication. Unfortunately, as with many of our patients, we lost contact with him before we were able to get labs. Time passed. We tried to locate him. Unfortunately, the phone we gave him wasn't working, and he also didn't have a backup contact, like a family member or a friend that we could reach. Then, about a year later, we were able to find his labs. We have we have access to Care Everywhere, which is a secure network, and we're able to see labs from emergency rooms or other healthcare facilities. So even though he wasn't able to come to our clinic to get these labs, we were able to locate them and confirm that he was cured. All right, thank you. And I'll pass it along to Reggie.
Thanks, Irina. So I'm going to talk about kind of the constellation that we've assembled of high impact strategies to reduce post-discharge care drop-off. My favorite is low tech. It's the bracelets that we give our patients with our program's name and phone number. And thankfully, we have a team of patient navigators, a small team that is weekly updated on our patients and able to have, conversations informed to, if a patient does call, get them connected to a follow-up appointment or their refill. Okay, so starting from the 12 o'clock position, we work with 7 of the Mount Sinai opioid treatment programs. Irina and I and Jacob go there every week. We kind of go to different ones each week. Patients at the opioid treatment programs have at least yearly blood work, but if a patient is on treatment with us, we're able to get a referral based on that blood work. We're able to do treatment week 4, end of treatment, and SVR labs there. We also have a 2-way referral relationship with the Rikers Correctional Facility. So if patients are started on treatment at Rikers and are discharging, their medical team will send us the information and we can schedule them for a follow-up appointment with REACH. Similarly, I've had a patient say, hey, I have to turn myself in. And we were able to contact Rikers with the patient's information, their medication, how far along they were on treatment, and have them continue treatment at Rikers. We also have contact with the Department of Homeless Services, so we're able to consistently send out a list of any patients that may be lost to follow-up or, unknown to us at the time where they are. And DHS is able to go through all of their shelters and let us know, hey, Mr. Jones is at this shelter, and give us another opportunity to reconnect. We also have additional inpatient substance use treatment programs. Like we mentioned, there's 3 in Spoke 1 and 1 in Spoke 2. And as Irina mentioned, there are long-term programs where clients can discharge. So with that third-party consent that they sign with us, we're able to reach out to their program and continue their medication, request labs, or in some instances, transfer their care to the provider at that next program and make them aware that if they ever want to work with us for primary care, we're happy to continue seeing them. And super exciting this spring, we work with the Pillars in Harlem. They have a mobile outreach van, and we're able to do weekly Narcan education, but also testing, both Hep C antibody tests and now RNA tests with our Cepheiad machine. So we're establishing relationships in the community where people who haven't been connected or maybe were lost to follow-up are starting to know, hey, on Wednesdays, we can meet REACH at Central Park or our other locations. We also work with the Mount Sinai Emergency Department. So if their health educators identify someone who has Hep C, and may be a good fit for REACH, they're able to notify us. But for all patients that we work with regardless, we set up chart alerts so that if that patient ends up in an emergency room that's connected to Epic, we get an alert. It can, the way I set mine up, I get the lab results and what services they're engaging with. So at times we're able to say, hey, this patient started medicine 5 weeks ago. We can reach out to the emergency department staff and even get them their refill so they can continue with a minimal interruption and keep making their progress towards cure. Next slide, please. Thank you. Okay, so one of the more frustrating, I started at REACH in 2022, and one of the more frustrating experiences was having a client's labs result post-discharge. So the first time we find out they have Hep C is after they've already left. So it's really exciting that we now have point of care tests, not only on our outreach van, but also at two of our spoke sites. And so their staff are now able to test folks based on the criteria that I'll discuss shortly. Or on the next slide. Yes. Okay. So here's our algorithm for point of care testing. It's pretty much, has the client ever been told that they have Hep C or ever been treated for Hep C? So that kind of gives us a sense of what the antibody test would be. And if anyone has been treated before or previously diagnosed, now the spoke sites are able to do an RNA test at admission. So our hope is that this will allow us to quickly identify folks that have been reinfected without placing too much of a burden immediately on the phlebotomy staff. So, okay. It was really exciting this spring to collaborate with the Department of Health, and you can kind of see the back of my head here, to go on site at the spoke locations and help train their staff. In addition to the Cepheid training, which is online, we were able to do hands-on training, practice, testing each other, talk about the different lens sets, and really get hands-on experience to see what works best. We were able to set up a workflow to make sure this is all being documented correctly in the electronic medical record at the site, but also to make sure that if someone is viremic, we're able to, in real time, get the result at REACH from this test. And we will continue to support the data entry processes. There's a lot of reporting that goes with these tests and the rest of our grants, so we'll continue to work together on that. And as this particular machine and process is new, the health department will continue to have bi-weekly check-ins with the nursing department at the spoke sites to make sure that we're informed with any issues they're having and continuing to share best practices. Next slide, please. Okay, so I'll talk to this one as well. Just the benefits of having point of care and what our goals are. So as I mentioned, if someone knows their Hep C history, at intake, we're now able to do a test. If someone has a short stay for all of the reasons that Irina mentioned, hopefully we're able to get this test at intake and start the conversation with them about treatment. So even if they leave, they know where they can go, or perhaps we can even get them started on treatment before they leave. And this can also prevent lab results. Sometimes, especially at intake, patients may be dehydrated. They may be a hard stick. And so full phlebotomy may not be able to happen at intake. It may result as a quantity insufficient. So because we're just doing a finger stick, we may be able to identify someone who is RNA positive and get them linked to care. And I'll pass it over to Jeff.
Thank you so much, Reggie. So I think what we want to stress is that this type of collaboration between a city health department, an academic medical center, and several inpatient substance use treatment programs requires taking into account the input of all the partners as well as the input of the patients that we have been serving. So this project really was a ongoing, continuous quality improvement initiative where the project workflows evolved over time in line with the feedback and data we were reviewing, as well as with the innovations in hepatitis C care and screening, such as the point of care RNA tests that Reggie just discussed. Um, to highlight again the model improvements over time, inpatient substance use treatment programs serve a very high-risk patient population with very high rates of both Hep C infection as well as reinfection. And it really is an ideal setting in which to implement on-site linkage to hepatitis C treatment through telehealth. Having our community health workers become non-salaried staff at the sites, which allowed for a full integration of our Mount Sinai Reach staff into the staff of the inpatient programs, as well as the pharmacy collaboration, improved our outcomes dramatically. 65% of the evaluated clients overall for the first 3 years started treatment within 9 days. And we saw dramatic increases over time in the number of patients evaluated and the percentage of patients who started treatment. Next slide, please. So we really want to encourage others to consider adapting this model. We believe that this approach is client-centered and really can enhance the services that patients are receiving at inpatient substance use treatment programs, and feel that we've developed that this demonstrated that this model is both feasible and adaptable. We certainly want to highlight the high rates of drop-off that occur in the transitions of care after patients leave the inpatient programs. As Reggie outlined, we consistently came up with strategies and innovations to try to reduce that drop-off, but it remains substantial. And I think that goes back to the characteristics of the patient population and the incredibly high rates of homelessness, unstable housing of the clients we were serving. Many of the clients had really no idea where they would be going post-discharge and had no contact information, which made it very challenging to get those SVR outcomes. But many efforts were made with our community governmental partners to optimize the post-outcome linkage to ongoing services and establishing documentation of cure. And we think that this approach really fills some critical gaps in the Hep C care cascade, and that the inpatient substance use treatment setting really captures a client population that is in need of hepatitis C education, treatment, and holistic services. Next slide, please. So finally, I would really highlight the tremendous opportunities that exist to establish partnerships across health departments, academic medical centers, outpatient clinical settings, and inpatient substance use treatment programs. But those are all very different cultures, and creating those types of effective partnerships takes time, relationship building, and hopefully what we've presented here today can serve as a model to inspire others to attempt that. The smiling faces certainly show the positive energy that we've been able to establish across these partnerships with the New York City Health Department, with our inpatient substance use treatment program, and with our team of community health workers and staff here at Mount Sinai Hospital. Thank you all so much for your attention to this presentation, and we hope that the work we've presented is both helpful and will lead others to replicate and adapt this model.